So one of the nice things about conference like this is that you can learn from others' mistakes. So I will show you some of my intraoperative fractures, and hopefully you will not repeat the same in your learning curve. So that's the idea of meetings like this. So in the 70s, when THR itself was new, there were a lot of intraoperative fractures because anything that's new will cause problems. And 80s and 90s, cementless devices became very common. And so a lot of fractures with cementless devices. Now the wave seems to be because of the new anterior approach, a lot of intraop fractures have been described. Now certainly cementless has got a higher rate of fractures. Peri published in 1999 with a 5.4%. But more recently in 2013, because of the new direct anterior approach coming, we have incidence of about 2.7% of intraop fractures, again very high. So Malka was described in 2007 that females risk factor, increased age, osteopenia, these are all very obvious. But as surgeons, we must identify certain factors of the local anatomy which will predispose them to intraop fractures. So if you have a stump-like proximal femur, that is a condition that can cause a fracture. If you have prior bone grafts, especially cortical grafts, either vascularized or non-vascularized fibrillar grafts, that's a situation where you can have fractures. So here's a patient of mine who had a fibrillar graft for a non-union refraction neck of femur. So I did a hip on her, and we kept broaching. It was very difficult in cortical bone, and finally we managed to put a hip in, and 6 weeks later she came. You can see the subsidence, and this young patient had to be revised with a distal fixing process, which is not good news. So whenever you have a cortical bone, be very careful. Another patient of mine is a stump-like proximal femur. I started off with an S-ROM, thinking it would be a good process for this situation. There was no way how we could get a S-ROM in this. Landed in a fracture, so I just did the socket. So I had to stage the procedure because I need to get an appropriate implant. And then 3-4 days later, with the appropriate implant, I was able to reconstruct. So a stump-like femur with no difference between the proximal bit and the diaphysis, an S-ROM is a bad choice of implant. So if you have a protrusion type situation where the introitus is very narrow, a dislocation would be very risky. Or if you have a hemiarthroplasty that is migrated inside, attempting a dislocation would be very, very risky, would cause a periplastic fracture. When there's implants in situ, it's been described that you must not remove the implants because your dislocation maneuver will cause fracture. However, the caveat to that, if you have a screw or metal wire protruding into the acetabulum, that becomes a bolted hip. You have a bolted hip, then if you don't recognize that and you try and dislocate, you're going to have a fracture. This was an interesting patient. I was doing a live demo of this surgery, and then I didn't notice that the implant, was really impinging on the acetabulum. When I attempted dislocation, we had a spiral fracture of the femur, and that had to be plated. And this was all during live surgery, so it was all very exciting to do all this during live surgery. And if you have a hemiarthroplasty with a very significant protrusio, there's no way you're going to dislocate it, no matter what you do. So the best way to handle this would be to do an ETO and dislocate the stem rather than the head. You dislocate the stem first, and then you pull out the head. That's the only way to handle these situations, and that's what was done for this patient. So if you have a calcar fracture, which we see during your non-cemented stem, it could be because you're using excessive force, or your direction or sizing was wrong, or it could be varus positioning. Now, there's a tip that if the size during preparation is much smaller than the templated size or the anticipated size, the stem is invariably in varus. So if you're not reaching that stem that you think is the right size, you are in varus, and you must do something to correct that. The two types of calcar fractures described. The one is a calcar fracture extending only up to the lesser trochanter. It's usually benign, and if you wire it, are usually safe. The other fracture is what you do not recognize. The patient comes 6 weeks, a trivial fall, and this is the large fragment with the center of the lesser trochanter, the lesser trochanter being in the center of the fragment. That is invariably a per-op fracture which was missed. This is not the patient's fault, this is certainly the surgeon. So two types of fractures. The second one, of course, is a very difficult situation to handle. Now the new approaches, of course, with what's unfamiliar will cause problems, and a lot of high incidence of intraop fractures have been described with a direct anterior approach, which is now gaining ground. Now, the paper in 2013 describes an intraoperative fracture rate of 2.7% with the direct anterior approach. So avoiding fractures, we're dealing with protrusio, you must do an in situ osteotomy. If you have a hemiarthroplasty with protrusio, it's better to do an ETO and dislocate the stem rather than the head. If you have any cortical bone in the neck, you must use a high-speed burr because broaching, as Amar was mentioning, broaching in cortical bone does not work. You must use a high-speed burr. and then you must broach. You must avoid varus. If you have a varus stem, that is going to cause a calcar fracture as well. So, if you look at revision situations, the chances of having intra fracture is much higher, 7 to 8 times higher. And if you have a diaphyseal fitting stems which are trying to size to get stability, that is again a risk factor for having an intra fracture. Impaction grafting has been reported to have about a 4% chance of having an intra fracture. Now, a long femoral stem may perforate the femoral shaft. This was what we were discussing in the morning with TKR revision stems. So here's a patient of mine whom I tried to use a long stem, and you can see how it has got a 3-point fixation and it has perforated the cortex. You can see that more clearly in this X-ray. So the rule is that a straight stem cannot hold in a curved bone. You'll only get a 3-point fixation. 3-point fixation works only if the secondary fixation, in addition to some other fixation you have. If it is an adjunct fixation, that's fine. But if this is your primary fixation, this will subside and fail. This is the commonest mistake I find surgeons making. They're getting 3-point fixation and they're not getting a scratch fit. So how to get a straight stem to work? You must either go as short as possible in a curved bone and be as thick as possible. That's the way it works. Or you must do an osteotomy and then you can get a long stem. You cannot get a long stem in a curved bone. That is the bottom line. The Vancouver group has again described this is not very useful like the periprosthetic fracture, so we won't discuss that. So the management of this would be you must have a high index of suspicion, and if you have a sudden change in resistance during stem insertion, then there's probably an intra fracture. You must deal with that. You must inspect the femur for fracture. If implant chosen on the base of templating is not stable, then something else has occurred and you must see what's happening. And if you have a change in resistance, that may be, if any doubt, kindly use a C-arm. So the principles of treatment would be you assess component stability, you also assess the fracture stability, and you do whatever you can to arrest fracture propagation. So the options are cerclage wires, you can use a hook plate or cables or plate osteosynthesis, or if in doubt, you must use a bypass with a diaphyseal fitting stem. I'll just 30 seconds on the socket. So sockets, monoblock sockets are prone for intraoperative fractures. But the acetabular fractures may be difficult to recognize. If in doubt, use a C-arm. You have to confirm component stability, and if in doubt, you remove it, reassess, and do whatever is necessary. So suggested treatment options are same as in revision situation. You can delay rehab, you can use additional screws, you may need to do a column reconstruction, or you may use rings and cases. Basically, all options used in revision surgery. So I will maybe go over the surgical tips. So the take-home message from intra fractures are it's a preventable problem. So anticipate that and identify the risk factors pre-operatively. Adequate exposure, care during dislocation and implantation is very crucial. There must be a high index of suspicion and you must recognize it per-op and do the needful, and you must be always prepared to deal with any such eventuality. Thank you very much.